Do any of you do OMT in geriatrics? Any of you? Okay, good. So I'm in true professorial way. I have no financial relationships to disclose. I will not discuss off-label use or investigative use of our presentation. However, I do disclose an abiding interest in world peace, possibly through osteopathy. So that's kind of where I come from in all of this. It's taking the high road. What I hope, after looking at my slides and hearing me, you will be able to describe the research on the number of conditions generally encountered in the geriatric practice, describe directions for research in OMT and geriatric conditions, and time permitting, and I will try to get you out of here by 6, describe an approach to applying OMT in geriatric patients. Because they are different, age and gravity have an effect on us that does necessitate some alteration of how you do the manual medicine form that we call OMT in people. Oh, I see. Oh, well, I just go off here. Dr. Hughes's presentation had a far more extensive epidemiology about the increasing tide of the baby boomers and older population. Steve Shannon, the ACOM president, had a couple of good articles here recently about the number of US citizens is increasing. You know, by 2050, I think Dr. Hughes's slide said by 2030, 20% of the population will be greater than 65 years old. And you hear more and more about how educating the interns and residents and medical students in geriatrics. Obviously, this is needed. Dr. Shannon went on to say that the elements that you want to look for in your evaluation of our senior citizens is to identify posture and gait abnormalities that contribute to gait and imbalance disorders. And this is what you try to treat. The joint malalignment, vertebral segment malalignment that alter your center of gravity. He recommends that we look at OMT as a non-pharmacologic treatment of somatic manifestations. And that you need to evaluate and treat somatic dysfunction that limit patient range of motion and quality perform activities of daily living. And you can do this with some very simple OMT applications that I'm going to talk about at the end. I also want to comment about something Dr. Hughes said, and that is, do you touch your patients? Several of the research projects I'm going to talk about had a sham placebo control that was just light touch, and it got clinical effects. So there is some, and it kind of messed up our OMT because we couldn't distinguish between was it the OMT or was it the light touch. And this is not to be underestimated, because the more that we learn about the electromagnetic field, the biofield as it's called, we interact with that through the mind-body as well as our touch. And so I think there are mechanisms of action for touch that are not yet understood, although I do think technology that measures the biofield is coming and will tell us an awful lot about that. There was a survey done by the AOA to determine the use of OMT in older patients. It was an anonymous online survey. I got it. I was one of the 629 members that got it, and I was one of the 197 that responded. So for surveys, that's not a bad number. And what they found is that OMT is used at the same rate for all ages. So it really doesn't matter what your age is. It's used about the same. And it was used most in respiratory and neurological conditions in the elderly. So breathing, nervous conditions, neurologically based conditions. And another finding was that the high velocity thrust technique was avoided in patients over 65, taking into account osteopenia, osteoporosis, and things that can easily break. Although my experience is that if you do the thrust technique well, you're not going to use too much force, and you probably won't break anything. So if you really, sometimes I'm talking to folks that have done HVLA all of their osteopathic life, and when I work with them and talk with them, have you ever seen an HVLA practitioner set up to do the thrust, be it a cervical or a thoracic or a low back? There's that pregnant moment there where they're getting just everything sorted out, and then they deliver the thrust. As I was palpating these folks, kind of touching the patient and watching the operator, what I found, and this may not make a lot of sense to you, but the thrust was delivered when the cranial mechanism was in neutral. Oh, my OMTologist out there understood that. Okay. My point being that there are physiological phenomena that, if you know how to assess them, assist you in doing any kind of OMT. And the cranial rhythm in neutral is one of these biofield phenomena, I think, that can be looked at from a research perspective. And that's what I'm trying to do. The research on OMT and pulmonary and respiratory conditions is one of the strongest in osteopathy in general, dating back to the late 1999 and 2000. Don Knoll, a geriatrician, studied OMT in community-acquired pneumonia. And in the old folks that were hospitalized, what he did was a protocol that I'm going to show you in a few moments that is designed to help the respiratory system work better. And the patients that got the OMT got out of the hospital faster, and they required less IV and PO IV treatment. This led to the profession's first major multi-site clinical trial, MOPSI, the multi-center osteopathic treatment in the elderly for pneumonia. And there were 5 centers. I know all of you know Dr. Hortos. There was, is she in Mount Clemens or Grand Rapids? Where's Dr. Hortos? Mount Clemens? Okay. That was one of the sites in the MOPSI study. And I had just gone to the Osteopathic Research Center in 2005 in the midst of this, and I was a treatment provider in the Fort Worth Center. And we had great hopes that this would alter the standard of in the care of pneumonia, in that it would suggest or be part of the database, evidence base, that you should do OMT in cases of pneumonia. Well, unfortunately, from 2000 to mid 2005 and beyond, the standard of practice in treating pneumonia was changed. They didn't put them all in the hospital, and they put them in the hospital, but it was very short duration. And so basically we got inconsistent results. The light touch got an effect. The main thing that we could say, and there's 2 kinds of analysis. The intent to treat, which has a missing data point, you just average the data, or per protocol. And the intent to treat, nothing was significant. But in the per protocol, which is the only data you had, the main thing we could say is that if you got OMT and to some degree light touch, you didn't die in the hospital. And the profession's $1.75 million for this study didn't give us the bang for the buck that we were hoping to. And so that's why you don't hear about it so much. But that has not daunted us from feeling that there is still something to offer. The OMT did get positive effects in reducing the length of stay in the per protocol analysis. So you do have some benefits there. It just wasn't the slam dunk that we hoped it would be. The MOPSI protocol, gosh, we had over 60 different intervention providers. We had every 6-month practice on the protocol so that everyone was doing it the right way, the same way. And so the profession really put a lot of effort into this. Soft tissue, the neck, rib raising, the diaphragm treatment, suboccipital inhibition, and then the lymphatic pumps. One of the interesting things about the thoracic lymphatic pump, and I've got a picture of it later, is that in COPD, it had an adverse effect. It was air trapping. So you have to be careful about what you're trying to treat. Now, even in this study in 2008 that Knoll and Degenhardt did, even though there was the air trapping based on the FEV1 pulmonary function, the patient still felt better. And the other limitation was that this was an immediate assessment taken right after the procedure was done. It wasn't hours or a day later. But since it's in the peer-reviewed literature, I need to tell you about it. So pneumonia, yes. COP, maybe. You want to be careful about the application of these lymphatic pump techniques that affect the lungs. If you heard Dr. Hughes's what you're referring to is the 1918-1919 influenza epidemic that put osteopathy on the map. And there they did not have the thoracic lymphatic pump. That did not come into literature until 1930. What they did was rib raising and just general spinal manipulation. And what you're saying is that the Spanish influenza that killed like 50, I have a whole slide on this, so you asked a question that's right in my wheelhouse. I just didn't want to put it in here because it wasn't necessarily geriatric population. That basically the viral infection would go into pneumonia. If you got the pneumonia, you had a 10% morbidity rate by the government records of the day. And so it killed 5 million people in the United States. But if you got OMT, you didn't die. It was a 0.01 mortality rate. So in 1918, 1919, the DOs, mostly you guys here in the Midwest, as somebody out in California where I am, at the time before the California amalgamation screwed us up, and we've been fighting years to get back in numbers, the reputation of OMT delivery by osteopaths and osteopathic physicians was just tremendously enhanced. And by word of mouth, boy, this OMT is doing something good. And that's one of the things I'm also trying to, this geriatric lecture is going into a 2 or 3 day workshop that I'm building up to, and I've been presenting on OMT in systemic disorders and physiologic functions to make the point that OMT is good for what ails you, not just musculoskeletal disorders where we do have the Cochrane level systematic review, meta-analyzed data proving that OMT is beneficial in low back pain. Yes? Yeah. It killed people of all ages, yes. Yep. And that was published in 1920 in the JAOA is where that got reported. So, yeah. And I didn't pay you to ask that question, did I? No. So, if you heard Dr. Hughes, the morbidity and mortality of falls, what was the slide? If you had a fall, you had a 30% chance of dying within a year. So the prevention of falls and fall management is really an important element in geriatric healthcare. 2 fairly recent articles in the JAOA in 2012 and 2013 summarize the approach. Some of this data was given in Dr. Hughes's talk in much more detail. 30% of boulders fall at least once per year. Falls are the leading cause of fatal and non-fatal injuries for people greater than 65. And the annual cost of fatal and non-fatal fall-related injuries is estimated at $32.4 billion. It will reach $34 1.2 billion in 2020. Where people that want to demonstrate the efficacy and benefit of OMT, where we get the attention is when we do the cost-benefit analysis that's going to save Medicare, save insurance companies money. Once you present data that show how it saves society and people money, then you start getting their attention and they will begin to pay for it. I bet that if some of you billed for OMT early on and you didn't get hardly any reimbursement, that's going to turn you off to trying to do enough OMT to bill for it. If they paid us more to do OMT, then I bet more of you would do it. You'd work it into your practice. So this is something that I'm devoting the rest of my life to. I am 74 years old. I'm Social Security beneficiary. I'm amongst this group. But I plan on living healthy to make it with a high quality of life until about 100 or so at least. High quality of life. And so I practice what I preach. I get OMT. I have a gluten-free diet, all those things that Dr. Hughes and the others have talked about. And I love what I do. I love standing here talking to you, talking about the research. And I'm going to talk more about it. So I have something to wake up in the morning enthusiastically to do. Anyway, in the Management Falls, the literature talks about what are the risk factors. Well, vitamin D deficiency, diminished strength and coordination, depression, multiple medications, and home hazards. Dr. Hughes's presentation covered all of these, and so in much more detail. And I would recommend that you take a look at her PowerPoint that's downloadable from the MOA website. I did that myself. I figured out how to go on your site and download the stuff. It's yes. I mean, as you get older, you look pretty active. I mean, how do you walk regularly? You getting? I mean, I want to know what you're eating. But you're doing it. You're moving, right? Okay. So you've overcome an infirmity to maintain an active lifestyle. Way to go. Way to go. Yeah. Okay. The mind and the spirit change with age, as well as the body. And part of that mind and spirit change is seeing the world around you and seeing how society just raves about the young, beautiful, energetic life that we now are usually not able to participate in as readily. You're preaching to the choir here about how you have to adapt. And which one of the speakers earlier said you really should use a walker? You know, I mean, you do have to adapt. Yeah. Okay, moving on. The study that Dr. Monson talked about, wherein we did it in Fort Worth, 40 healthy elders, 20 got the OMT and 20 did not. There were 4 visits for OMT, or just a visit in to have your balance measured. And this pressure plate, this was state of the art, center of pressure We did the 3 balances, eyes open, eyes closed, and then with arms out like this, 3 different conditions. And what we found is that with eyes open, by the 3rd visit, you were significantly more stable. There was less, the AP, the anterior posterior sway is what all of the researchers tell us, that's what makes you fall down. The forward leaning and you fall down. And that was what was significantly reduced by the OMT. The lateral, medial lateral, that was not changed. And then with the eyes closed, there was still an improvement, but it wasn't statistically significant in the AP sway, and the side-to-side sway was not significantly different. And then the Romberg out front, that was improved, but not statistically significant, and the medial lateral was even less significant. So this was one of the first tests, and it inspired another test. Oh, this was what I wanted to, this is the protocol. This is what we did. We worked up and down the vertebral column. We loosened up the sacrum. We did a side leg, shoulder, and scapula myofascial release. We did counter strain and muscle energy to loosen up the neck. We did this occipital atlantal decompression. I got a picture of that later. A much more detailed cranial maneuver of the venous sinus technique, and then to do the frontal lift. This is cranial work, because what we postulated is that the improvement in balance was the temporal bone alignment improvement, and the equilibrium control apparati, the semicircular canals, were brought into greater symmetry by our manipulation. Also, if you really get into the weeds of neuroanatomy, we also receive our motion, our position in space and motion from the suboccipital nerves in the back of the neck. So the back of the neck and the semicircular canals in the temporal bone, if you have some way of impacting those with your OMT, you are probably going to restore normalcy and give the person a greater advantage of using their faculties to keep their balance. And I do this on every patient over 50, given the pre-geriatric folks a little head start. A second study, I put it in because it does show that OMT helps people that are dizzy. The average age was 49. It's not really geriatric, and there was just 16 folks. They used a state-of-the-art, this plate the person's standing on, they got straps to keep, so they don't fall down. And there's a number of these conditions that give you a composite score. And it's the NeuroCom. We are going to use this in a Parkinson's study. We're trying to get going at UCSD, because it is a state-of-the-art balance and equilibrium control, and it gives us more data than that pressure plate that we had at North Texas. And basically, if they got the OMT, they really were better. This composite score immediately after OMT, and then 1 week after the OMT, they were still significantly improved, less dizzy. Now, when you get into the weeds of it, vertigo and dizziness are slightly different, though in this study, there were people that had both diagnoses, but they had a predominance of people that had been diagnosed with vertigo, and they got their patients mostly from a clinic that had mostly vertiginous patients. And you might ask, well, was meclizine really the medicine they give? They had them not take the meclizine for a week before they did this. Musculoskeletal conditions. Dr. Monson also started to talk about this study, published in 2002, was on shoulder somatic dysfunction, frozen shoulders, stiff shoulders. They used Spencer's technique. Now, I bet all of you going through OMT and your medical school training probably heard of Spencer's technique, because it was about the only thing we had going for shoulder manipulation. Basically, you try to put that shoulder through every conceivable range of motion and to shake it up clear down to the labrum in the shoulder joint to get things moving. That's what it was done. Dr. Nabel was a geriatrician, and Russ Gamber was the main, I call him OMTologist. Yeah. You can quote me about OMTologist, okay. You know what I mean, I hope. She assessed the patient, but she didn't know what group they were in. And basically, all planes of motion improved the OMT group. Function improved, pain improved if they got the OMT in cases of shoulder somatic dysfunction and pain. Here was an interesting one about OMT. This is more an observational study in knee pain and leg length difference. I threw this in because short leg, long leg is always one of the things we document when we do a structural analysis to describe the nature of somatic dysfunction. And lo and behold, knee pain was most severe in a short leg. And as you might say, well, that's godmother apple pie and obvious, but here's some actual data. The answer to this, and Noel did not go on to do OMT to see if the knee pain could be, the arthritic pain could be changed. In my practice clinically, I treat arthritic knees all the time, and my anecdotal experience is that you do improve range of motion and lessen the pain if you treat the knee. And I can tell you what I do to treat the knee. It's mostly myofascial release and some muscle energy techniques. Working with folks in the nursing homes. This is a pilot study. My good friend Karen Snyder and her husband Eric in Kirksville had 21 patients in a Kirksville nursing home. 8 received OMT, 7 light touch, and then 7 had treatment as usual. And this was an observational study looking at their medical records. And the patients had interventions twice a month for 5 months for a total of 10 treatments. The treatment as usual had no treatment. And the results were the OMT and the light touch had fewer hospitalizations and decreased medication usage compared to the treatment as usual group. Light touch did something, as did the OMT, in comparison with usual treatment. And these, again, now this is a very small study. It would be considered a pilot study. You're not going to affect the standard of practice on this. And it's so darned expensive to do a clinical trial that this would be an easy one to do in all sorts of assisted care facilities, nursing homes. And if you can show that the application of OMT lowers fewer hospitalizations, decreased medication usage, you really could, I think, show that the form of manual medicine we call OMT would be quite beneficial. Standard care. They're in the nursing home. The geriatrician or whoever covers the nursing home just took care of whatever their ailments were. Standard of care. Standard practice in Kirksville, Missouri, whatever that is. How many of you went to school in Kirksville? Oh, gee. Well, it's probably changed in the last 50 years, but yep. You got standard care, yes. There's all sorts of jokes about that. I really do encourage you to look at some of Carol Monson's slides where she talks about the meditation, the breathing, the other things you can do that have a beneficial effect. I personally think there's something to that. And more in the nursing home that I go to treat a couple patients, they're doing that more and more. Parkinson's disease. We actually have a study done in 1999. There were just 10 Parkinson's patients got OMT, and a separate group of 10 patients were given a sham control procedure, tested in the same manner. There were the treated group of patients with Parkinson's, statistically significant increases were observed in stride length, cadence, and the maximum velocity of upper and lower extremity movement. Their gait biomechanics were enhanced by having the OMT. There were no differences in the control groups, and this was just one single session of OMT had an immediate impact on the Parkinson's gait. And this was done in 1999. And people said, well, that's interesting, and nothing was ever done about it until in the last 5 years. The American Osteopathic Association, if you've been following it, has pooled their resources and has more research money, as much as $150,000, which can give you a fairly decent, reasonably powered number of subjects in a study. And there are now 2 funded clinical trials on the impact of OMT on Parkinson's disease. One is Sheldon Yao at the New York School and Kendi Hensel at the Texas College of Osteopathic Medicine. So I am hopeful that in the coming years, there will be evidence that show the benefit of OMT in this condition of Parkinson's. The Sheldon Yao group at NY, these are part of his, Yao's names at the end of about 20 co-authors who are part of this study. And their outcome measures were this mini balance evaluation system test, sensory organization test, and movement disorders, the Unified Parkinson's Disease Rating Scale, this MDS-UPDRS. There were 11 subjects who were randomly assigned to bi-weekly, twice a week OMT treatments for 6 weeks, or weekly counseling sessions. There, in a 3-arm study, you have the intervention, OMT, and then you have a sham placebo group, and then you have standard care. This is the random controlled trial design for practically everything. And their sham or comparison group are counseling sessions, which is an interesting way to go about it. This was based on a small number. There were no significant changes in this sensory organization test or the mini balance evaluation system test, but there was significant improvement for the OMM group for this MDS, the Movement Disorder Society Unified Parkinson's Disease Rating Scale. The data, if you go into it, would suggest that if they get as many as 30 subjects, that these results will be significant as well. It's just underpowered with a small number of subjects. This is all, the reason I'm able to, this was published in a journal called Neurorehabilitation. So it was peer reviewed, and the editorial board of this journal accepted the osteopathic treatment. It's amazing how 20 years ago, New England Journal, JAMA, would not accept anything OMT if OMT was in it. It's just a world of difference these days. And our unified residency training standards and the last 20 years that go into that, I'm sure you all are aware. My opinion, I was a residency director at Wisconsin and Madison for 3 years as this unified residency training standard initiative was started. And I'm all for it. The problem for some of our smaller residencies is that they won't pass the ACGME standards. And so we're losing a few, but all of our former DO-only residencies are being accredited by ACGME, the Accreditation Council of Graduate Medical Education. The price that ACGME paid was that they have promised to honor our OSPEC principles in practice, our OSPEC philosophy, our hands-on practice is accepted in MD land. We've reached acceptability. And what turned the tide, in my opinion, is in the last 10 to 20 years, our DO graduates performed just as well as the MD graduates on all of the national board tests and in the allopathic residencies in which our DO graduates graduate. I bet some of you may have done an otherwise MD residency and you kicked butt. You performed. You proved that you were just as competent. You had just as good a medical knowledge. And the MDs cannot deny this anymore. We have proven our mettle. Now, the ink isn't dry, and it's conceivable that our OSPEC principle of practice would not be honored as the current negotiations now have it. And that's the only thing that makes me a little squirmy. But if you know graduate medical education, they have ACGME has residency review committees. These are the committees that set the standards for residency training. And they now have a neuromusculoskeletal medicine, RRC, and they have a big OSPEC principles in practice, RRC, that are setting the standards for how much OPNP and OMT is included in the curriculum of primary care, especially family medicine, internal medicine, OB-GYN, pediatrics, and orthopedics. So I think AT still won the war, is how I would suggest. I think the proof of that will be as the profession goes forward. One of the details of this I do want to share with you, the current AOA president, Boyd Boozer, DO, the dean and president of the Pikeville College of Ospreay Medicine in Kentucky, is a past American Academy president. He was chairman of the OMM department at New England School for years, and he has been a very able advocate and representative of traditional osteopathy. And I think his credibility in this arena helped carry the whole AOA busload, train load forward in this. So I want to make sure he gets some acknowledgement. You folks in Michigan made a big difference in the way you have accepted OPP, OMM statewide. You know, heavens, Ohio and Michigan are just, God, you know, it's more than football, you know, the competition, but you have all the opties, you have a wonderful graduate medical education training infrastructure that has really been noticed by the MDs. And that strength of the OSPEC medical profession has been a large factor in how this joint ACGME, AOA, Unified Residency Training Standards initiative has come about. So if you don't know about that, heck, you probably have been in your other CME annual convention. This is the spring one, right? You know, you probably have heard all about this, and you probably get the updates from the current AOA president-elect who visits and tells you what this is all doing. But as an OMTologist myself, I have been very much involved on the ground level trying to make this come about. I'm even developing, I've written a book with 2 other authors on teaching the MDs to do OMT. We've had some pull on that. For the last 6 years, I've been first at the University of Wisconsin and now at the University of California, San Diego, MD clinical residency institutions, and a number of the MDs have responded to our work. We call it OMT Boot Camp, to introduce them to OMT and teach them some of the basic skills they can use in 5 minutes in an otherwise busy practice. So I think there's hope for the stabilization of OMT being done in medical practice in the United States, period. Okay, Parkinson's. Promising areas of research. Much of this relates to any traumatic brain injury, dementia, Alzheimer's. Before I talk about the lymphatic system, I think that osteopathy, osteopathic medicine, OMT, has a great deal to offer in the neurosciences, particularly because of the techniques of cranial, balanced membrane tension, ligaments articular strain that get at the dura mater, the membrane around the brain and spinal cord. We seem to be able, it's a whole other lecture I give on the cranial concept. The cranial bones do move. The dural membranes inside the head are movable. And we think that this can have a beneficial effect on all of these wounded warriors that get blown up by the landmines, improvised explosive devices. And there is a study out of the Beaumont Army Medical Center in El Paso. Unfortunately, it was craniosacral therapy, which is a kind of hands-on work done by your Michigan State University expatriate John Upledger, who started the Upledger Institute that does craniosacral therapy. But craniosacral therapy and this Army hospital in El Paso helped improve the soldiers with traumatic brain injury. Less dizziness, less headaches. Yes. 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 I'm now a part of a clinical trial at UCSD on people with traumatic brain injury. We are recruiting them from the concussion clinic, and our preliminary data is showing that on the migraine intensity disability scale, they are improving from the OMT. And the lymphatic system. Basically, I'll summarize these slides. It's the cerebral spinal fluid in the brain. The idea is that there aren't any lymphatics in the brain. And so how does the waste products of cellular metabolism? We've all heard of these Lewy bodies that build up in the beta amyloid plaque that is found in Alzheimer's. My opinion and anecdotal experience is that the cranial manipulation improves the production and pumping of cerebral spinal fluid in the brain, which flushes out the waste products of cellular metabolism in the brain. It's a simple CV4. If you can do that, compression of the fourth ventricle, and I've got a picture later to show you. Unfortunately, the only cine radiography that shows the improvement of cerebral spinal fluid flow, the intervention was done by a chiropractic snap of the neck. And even something like that on cine radiography shows a speeded up, more robust flow of cerebral spinal fluid in the head. And I kind of think our osteopathic treatment is a heck of a lot better than chiropractic. Chiropractic has its place, but I think the way we osteopathic physicians do it is a much more detailed, much more anatomically aware kind of hands-on intervention. So we get that cerebral spinal fluid flowing by the lymphatic system. I think we have an awful lot to offer any kind of dementia or Alzheimer's. And I'm applying for grants to the Alzheimer's Research Association, and so far I have not been successful, but I'm going to keep knocking on the door. Pardon? Of course, of course. What you put into your body. Now, I am not aware of any nutritional intervention that diminishes dementia or Alzheimer's, but the discussion about diet in general to reduce the inflammatory load on the body, I think can have an effect. You know, all these gluten-free paleo diets, I think it's kind of, to me, a common sense sort of thing. But to my awareness, there isn't any published research that correlates a certain nutritional benefit for dementia or Alzheimer's.
Well,
Really? Okay. Well, that's the adverse effect. What can you do good, as this gentleman is at? I think gives the implication of your, does diet affect it? Alzheimer's? Wait a minute, you're 89 and your mother's in a nursing home? Means she's still alive. How many black walnuts a day, sir? 3 a day. You heard it from the practitioner here. Okay. I'm up against a time limit here. Well, what I'm just trying to say is they now have found lymphatic vessels in the brain as well. They are in the dural membranes. Now, these were in rats. And the reason why this is important is the lymphatic system has a lot to do with the immune system. And so now the brain, we don't know what effect this is going to have, but lymphatic vessels have now been found in the brain. That was my point there. And now, I get a chuckle out of it every time. My experience, and in the end of life, the application of OMT, regardless of actual symptoms, applying OMT to people in the terminal stage like can ease the pain and struggles typically occurring at this time. The diaphragm release, rib raising for pulmonary and respiratory function, lymphatic pump for the immune system, cervical soft tissue, I think helps the CNS and the CD4, really helps balance the nervous system. These are pictures of doing the diaphragm release. There's several ways to do it. It's very gentle. You're not pushing or pulling anything very hard. The rib raising. You're at the side and you're lifting those ribs, first one side, then the other in a rhythmic way. The proposed mechanism of action of that is it's right over the costovertebral angle. You're getting that angle moved. What's on the inner surface of the body cavity? The sympathetic nerve chain. And so you're doing something that increases rib motion and probably has a balancing and opening effect on the autonomic nervous system part. Pericardial sac. I think you can improve and help cardiac function if you remember the anatomy of this pericardial sac around the heart. And basically, you can, through the ribs, if you develop the sense of touch, you can feel the whether or not that heart area is really hard or soft. And this is a picture taken Your Body at Texas. This is a study on post-coronary artery bypass surgery. And the thrust of what he was doing was that the patients who had OMT after the bypass surgery had much better heart and lung functions if they got the OMT. Got out of the hospital faster. And that's the only picture I could find of the hand position for doing anything on the chest to help. It'll help lungs, it'll help heart if you just get over that. If you'll be working on a patient like that. The thoracic lymphatic pump, it was shown effective for the pneumonia, but the COPD study suggests you need to be careful about that. And so when I do lymphatic pump, I always use the pedal pump. You can get the same thing from pushing on the feet, and you get the abdominal slosh going. Most of the lymph nodes make T cells, B cells, cytokines that are an important part of the immune system. And most of that comes from the GI tract. And so even though it's a thoracic lymphatic pump, you're putting pressure on the abdomen to activate all this lymphoid tissue. And so I think the pedal pump is just as good. Cervical soft tissue, myofascial release. I'm showing how you just basically massaging, stretching the neck, and then this compression of the fourth ventricle. This is the hand position for that. And if you ever take any kind of cranial course, you learn how to do it. The CV4 has often been called the osteopathic aspirin because basically you want to be putting some pressure on the occipital bone.
Right, under the occipital bone and hold it until you feel the movement and bring it to it. But I'm learning crossing.
As long as you got some part of your thumb in the right spot, there's more than one way to skin a cat. On kiddos, I do it like this. You know, thumb and the first finger in that area because you can't get your hands in the proper place on the pediatric, you know, small heads. Okay, I am out of time. And so I want to thank you for your kind attention. I'm going to be hanging around. I'm happy to answer any questions that you might have, hear your hero stories, and just generally love you. You know, love is the answer. What's the question? I think our touch conveys love.